our next speaker is Bob Grant, who is with the Gladstone Institute of Virology and Immunology and associate professor at UCSF School of Medicine. And he was the principal investigator, I guess still is, of the iPrEx study, and will talk about the safety issues in that study.
Thank you. Thank you, Veronica, and thank you all for this opportunity to describe our latest safety findings from the iPrEx study. Just to remind you, this was a clinical trial of men and trans women who have sex with men that was sponsored by the NIH with co-funding from the Bill and Melinda Gates Foundation and drug donated by Gilead Sciences. We found 42% decrease in HIV infection rates on an intention-to-treat basis. Among those with detectable drug in the blood, there was a 92% decrease in HIV risk. I've been asked to focus on the safety data, but just to remind you, we enrolled 2,499 MSM and trans women at 11 sites in 6 countries on 4 continents. They were randomized 1-to-1 to receive daily oral Ftc TDF versus placebo, and followed monthly on drug for HIV seroconversion, adverse events, metabolic effects, HBV flares among those with active hepatitis B, risk behavior and sexually transmitted infections, adherence, and if infected, drug resistance, viral load, immune responses, and CD4 counts. At the end of the study, we have 2,124 person-years of observation on the active arm of the study. Just to review the adverse events, when we look at depression, grade 3 and 4 adverse events, deaths and serious adverse events, we see no difference between the placebo arm and the active arm of the study. The one death in the active arm was after a motorcycle accident. In terms of laboratory parameters, we evaluated an extensive chemistry panel and hematology and really found no signals associated with the active arm of the study except for creatinine elevations. We analyzed creatinine elevations in 2 ways. One, as scoring any elevation in creatinine above the upper limit of normal, and we can see that 2% of participants had such elevations in the active arm versus 1% in the placebo. This is not the usual way that creatinine elevations are evaluated because the vast majority of abnormal creatinines will be normal on repeat testing, even within 7 days. And this is, in fact, what we found. There were only 5 people who had a creatinine elevation that persisted from one visit to the next, and they all occurred in the active arm. This trended towards statistical significance. Importantly, all of the creatinine elevations resolved after stopping PrEP, and 4 of these 5 individuals were rechallenged with Ftc TDF and did not have a recurrence in their creatinine elevation. There was no difference in other laboratory parameters between the active and placebo arm, including phosphate, amylase, liver function tests, and hematological parameters. We evaluated clinical adverse events in the study. I understand that there were approximately 200 different clinical adverse events that were evaluated over the course of PrEP. In this slide, we call out the few that trended toward statistical significance in terms of differences in the active arm. There was no difference, by the way, in diarrhea, which had been reported in some microbicide trials. But we did see trends toward an increased number of people reporting headache, nausea, or unintended weight loss. These side effects typically occurred in the first few weeks of Truvada use and resolved thereafter. So in this way, it's similar to the treatment experience for HIV infection. Drug resistance is always a concern whenever antimicrobial agents are used. We did not see any FTC or TDF resistance using genotypic or phenotypic assays that have been clinically approved for medical decision-making among the group that had emergent infections on Truvada. And this finding of a lack of drug resistance is consistent with drug level testing, which showed negligible levels of drug or no drug detection at all among seroconverters in the active arm of the study. We also see evidence of negligible drug exposure in terms of viral load, which was comparable in the active and placebo arms of iPrEx. There were 2 cases of Ftc resistance, both in the active arm of the study and both in people who were infected prior to starting PrEP. And their infections were identified by retrospective analysis of RNA testing when they seroconverted in the first 12 weeks of the study. This was protocol-specified testing. Now, we know that the clinically approved, or the assays that are approved for medical decision-making are relatively insensitive for the detection of minor resistant variants. So we did an allele-specific PCR assay that can detect resistant variants at 0.5%, and we do not see any additional cases of drug resistance using this robust and highly sensitive allele-specific assay. Importantly, the 2 cases of people who were infected at baseline and then developed Ftc resistance, we followed their infections over time and found that the resistant variant wanes to below 0.5% within 6 months after stopping Truvada PrEP. This level of drug resistance has not been associated with impaired virologic responses to drug classes like nevirapine. We're still missing data for FTC responses in these patients. Behavior is an important concern. I need to wrap up. We saw decreases in reported numbers of partners. These decreases were also observed among the subset of iPrEx participants who thought they were taking the active drug. And we saw increases in condom use. So we are not seeing any evidence of risk compensation. To the contrary, we're seeing evidence of synergies between prevention interventions. This is very similar to all other clinical trials in the HIV field. And we now have confirmed a decrease in HIV incidence measured as the prevalence of acute infection over time. There's a 4-fold decrease in HIV incidence, or the prevalence of acute infection in the placebo arm, and a 6.5-fold decrease in the prevalence of acute infection in the active arm. Again, confirming using objective measures a decrease in HIV risk associated with enrollment in a PrEP program. There is a small, less than 1% decrease in bone mineral density in the active arm compared with placebo. This is not associated with fractures, and it did not progress after the first 6 months. And the amount of bone mineral density loss is less in the prevention setting than in treatment settings. The prevention trials plotted here in green colors, and the treatment studies showed here in blue. So I'd like to thank everyone who contributed to this project.